right. I'm going to talk about impact, but first of all I'll tell you a little bit about myself. I'm a perinatal epidemiologist working at SAMRI in the Healthy Mothers, Babies, Children's theme. And I'm going to take a slightly different tack. Impact's got a different organisational structure and history, so it'll be a bit different from perhaps the other talk. So I want to concentrate on our implementation challenges. So here's our logo. PERSANS, our Perinatal Society, has been going for over 20 years, and so has Impact, which is our trials network. We're a loose trials network. We haven't got any centralised funding. We have probably conducted over 100, perhaps 200 trials over our history, from very small to very large, single site to multi-site to international. So we're very diverse and we're very distributed, which means that we perhaps do things in a slightly different way than maybe some of the other more ACTA networks that you've heard about. So I want to focus on implementation because it is a real challenge for our diverse and dispersed area. So in line with what Jeremy was talking to us about early today, what is it that we need to know to start implementation? We need to know what's gone before. We need trials that are adequately powered and funded. They have to be important questions. And we have a system within Impact where we have two categories, impact reviewed and impact endorsed. So impact reviewed means that they must have been presented at one of our impact meetings. We aim for 2 to 3 to 4 meetings a year, which being dispersed across Australia and New Zealand sometimes is a challenge of geography and finances. Impact endorsed is something that's rather newer. So impact endorsed is that the trial must have been presented in its formative stages to an impact meeting, and then it must go through a system of fulfilling the criteria that have been preset. So only a few of our trials so far have been impact endorsed. It's a fairly new system. So again, to echo what we heard this morning, what is it that we're trying to implement? Is it the trial results? Is it the systematic review conclusions? Is it guidelines? Or is it the recommendation of guidelines? So I want to go through a couple of examples. I'm not going to describe, as I said, impact in total, but I wanted to highlight a couple of things, and they just happen to be two trials that were fairly prominent in this year's ACTA Awards. So this is the Nero Trial, DHA and preterm babies. The principal investigator was Carmel Collins, a colleague from my institution, SAMRI. And this was looking at preventing a nasty lung disease in preterm babies, bronchopulmonary dysplasia. Had some promising results in a trial that was done with DHA, fish oil, in preterm babies, which looked promising, although it wasn't one of the pre-specified results. So this got the award for excellence in statistics, and we certainly needed excellent statistics in this one. To our surprise, we did find that more is not always better, so it was a null trial, perhaps a slightly negative trial. And it got published in that famous New England Journal of Medicine. We now have NHMRC funded follow-up, which is important because contrary to our expectations, it's not follow-up to look for further benefits. We're looking to track that there aren't further harms. So that is perhaps a de-implementation before it started. Maybe we've nipped this one in the bud. So maybe this is the way to do it, but it wasn't the intention, and I think goes to show that whatever our preformed ideas are, we can always get great surprises. So another one, this happened to be the overall 2018 ACTA winner, and this is the placental transfusion trial, which is cord clamping, umbilical cord clamping in preterm babies, and the principal investigator was William Tano Morty. So the landscape for this, the background is that Cochrane review a couple of years ago in preterm babies did find less need for transfusion, and a later systematic review has found reduced baby death. In the guidelines, the All-Core guidelines, for example, people who express concerns about resuscitation and making sure that baby is attended to very quickly. So the slogan for this in ACTA speak was "Wait a minute." So we're not quite sure about whether that is entirely what the message should be, because it's more complex, of course. So the baby needs to be checked to see that it's healthy. It's not wait a minute for every baby. So this just gives you a little bit of a flavour of the complexity of implementation. I want to talk now about a piece of work that we are doing, which is quite an involved piece of work around omega-3 fatty acid supplementation in pregnancy. And this is clearly part of IMPACT, but also part of the SAMRI work that we're doing. So we have just updated a Cochrane review, which was slightly old and raggedy at the edges. Now adding 63 trials, which was quite an extensive body of work. Includes Domino there. That's an Australian trial, so it did cover a number of Australian trials, that one in particular. So nearly 20,000 women now involved, and just a couple of things there, quite diverse doses and how you might give the fish oil. So we found in this update reductions in both preterm birth less than 37 weeks, birth less than 34 weeks, and an increase in prolonged pregnancy, induction of labour at term, no difference. So telling us that yes, preterm birth reduction and certainly extending gestation, but is able to be pretty much managed these days. So the Cochrane review update includes all risk women, low risk and high risk. Doses varied, usually above 500 milligrams a day. The results of the systematic review are consistent with the earlier version in individual large trials. Again, that argument about is a one large trial, does that trump smaller trials, a number of smaller trials? Lots of issues around reporting biases, which I won't go into, but is relevant in the interpretation. So what do we face with here? The orthodoxy has been that fish oil in pregnancy is not really about preventing preterm birth, but more about neurodevelopment and fetal growth. And so the industry, which is a major player in this topic, of course, has been going down the line that antenatal supplementation with fish oil is all about improving babies' brains. And this clearly, through the industry messages, has an influence on what women and families believe. And so just a bit of work that a colleague, communications colleague, has done was look at the media around omega-3 supplementation. As you can see down there, it's all about brain and other development, learning and behaviour, growth and development. So multiple reports of health claims there cited, but nothing about preterm. So again, this is our landscape that we have to consider. So blank sheet for preterm, all of the concentration is on growth and development of the baby. Quite a formidable landscape to transverse now. Just to complicate things just a little bit more is that we've just finished recruiting the ORAC trial, which is another large omega-3 fatty acid trial in pregnancy. So 5,500 women. We don't have the results yet. We're analysing as we speak. So what we're planning to do is incorporate the evidence from the Cochrane review into an update of clinical practice guidelines. So these are the pregnancy care guidelines, which are, I think we can call them living guidelines now. So they are, have had a number of versions, and we're in constant update mode. So the other stage is a stakeholder engagement with consumers and healthcare professionals to understand what are the barriers and enablers, and importantly those beliefs. So we're in the moment we've been fortunate to get some MRFF funding to design and test implementation strategies. So some of the issues around that we're working through at the moment is do we do a blanket versus a targeted approach in our implementation strategy? What's the simple message that we can create? Cost and benefit, which probably is one of the more straightforward things, because if we prevent preterm birth, clearly the benefit quickly outweighs the cost. We have to be very careful that we don't create more inequity. We have some preliminary data to indicate that, and probably not surprisingly, that in women with fewer resources are likely to have lower baseline omega-3 levels. We don't know as yet whether that translates into that group being better candidates for this intervention. We're navigating the very interesting world of suppliers and regulators, and we're thinking about who actually implements this. So it's not something that's a prescription. Is it women and families looking at supplementing with fish oil or changing their diet, or is it mediated through health professionals? So I think it's exciting times ahead. We finally have a funding source, an increased funding source. I'll take Davina's findings that we do have some translation money through other sources like NHMRC, but the Medical Research Futures Fund is a clear source that's going to help us be able to do much more of this work. And this is also counterbalanced by some other things that are happening in our implementation world, and there's been a focus, at least in the perinatal area, on care bundles, and they're not necessarily preceded by clinical trials. So again, a little bit of a tension perhaps between implementation RCTs versus quality improvement, and that might be an interesting topic for discussion later about are they, do they meet or do never the twain meet? And lastly, it would be remiss of me not to mention magnesium for neuroprotection, which was certainly a very interesting journey that we had, and we went certainly around the research cycle once and were able to get from about zero uptake, and this is in preventing cerebral palsy, for example, from zero uptake to about 98% within a year. But this is a cautionary tale about sustainability that has dropped at one site to now 60% from almost every eligible woman getting antenatal magnesium sulfate. And we've just been talking with Carmel about outcomes and interventions. I think part of our issue there is that we have some mechanisms like the neonatal network, for example, in Australia and New Zealand, that collects the outcomes in the neonatal world, but we don't collect interventions so much. So, for example, here, this involves now going into individual medical records to get these figures. So again, a plea that we need, if we're going to do proper implementation, we need audits of interventions as well as outcomes. And that's it.